So June is Men's Health Month, and this morning we'll be hearing about the groundbreaking advancement transforming the way prostate cancer is diagnosed and treated. With me now, consultant urologist, Dr. Belinda Morrison Blidgen. Actually, my doctor, believe it or not. How you do?
Good morning. I'm good.
Great to see you. So let's start with an overall thing before we get specific here. Prostate cancer. What that and how often and when should we start?
So prostate cancer, again, very, very common. Commonest cancer we diagnose in this country, and certainly commonest cancer in men. We should start checking from age 40 in Jamaican men, and we should be doing it once a year. So the tests remain the same. It's a blood test which checks for a substance called PSA, which is in the blood, and also doing a physical exam, the rectal exam, all right?
Yeah, which I find to be an issue with a lot of people.
It is an issue with a lot of people, and the truth is, if we must be honest, the blood test is far more sensitive in picking up an abnormality. By that I mean, you can have a normal physical exam and the blood test is what tells us that something is wrong. So I've been more nuanced as the years have gone by. I'm not as rigid. I tell patients, listen, if you're really so turned off by doing the physical exam, still come in, have the blood test done, and we can have conversations moving forward.
So the blood test can tell whether you have prostate cancer or not?
The blood test is the more sensitive of the two.
Okay.
If it is high, there is a strong suspicion that there's cancer there, and you may have to move on to further tests.
Okay. What about, as I said at the top, this new advancement? What are we talking about?
So there are a few new advancements, not just for men who have prostate cancer, but for men who have an enlarged prostate. So from the perspective of prostate cancer, we can talk about tests that help us with the diagnosis of prostate cancer. What is called a multi-parametric MRI. So you must know of MRIs in sports. You do MRIs for joint injury. You can do an MRI of the prostate gland. It's a very simple, non-invasive test. You go in a machine, it scans the pelvis for about a half an hour, and it's probably the only and best test that can look within the prostate and show you if there are lesions there. Now, whereas it's not recommended that you do that once a year for screening, but it helps us a lot if a man does the blood test and it's high, and we want to know how to proceed. A man can do this scan, and the scan can show us if there's a suspicious area in the prostate. So it directs us when we're going to do a biopsy. It improves the yield of the biopsy, and it is extremely important. So I would say that's a new advancement that we've had in the past 10 years or so. And certainly across major parishes, many organizations have MRIs available in radiologist suites.
Okay, so you have the blood test, you have the rectal exam, and you have the
MRI, which helps you.
Okay, if I wanted to just do one of them, which you think would be the most
We always
important?
say still start with the blood test. Still start with the blood test. Because if the blood test is negative, you don't have to have any further tests done.
Okay.
If the blood test is high, I may say, listen, try and get the MRI done, and then that MRI will then direct me as to whether or not I do need to do a biopsy, and if I do a biopsy, it helps me to target those suspicious areas.
All right. So if you have prostate cancer, your prostate is enlarged?
No, not necessarily. Two separate entities. You can have prostate cancer without having an enlarged prostate.
And you can have an enlarged prostate and don't have prostate cancer?
Correct. As it relates to prostate cancer as well, in terms of new innovations, genetic tests. There's so much that the genes can tell us about someone. And you can do genetic tests for various things. But for prostate cancer, we can use blood, we can use urine, and it can test for the presence of certain genes that are high risk of you having prostate cancer, especially if you have a family history. Those tests are now being done through the Caribbean Genetics Institute, which is located at the University of the West Indies. Utilize them freely. So a man comes, he has one of those tests that is high, the PSA, right? Whether or not I do an MRI and I see something suspicious, I may send him now to do a genetic test. And it's a very simple thing. I do the rectal exam, I ask him to pee in a cup, and he goes to the lab with that specimen. And they send that specimen to a lab where they can check for specific genes that are high risk for getting aggressive prostate cancer. When that test comes back and it's positive, I now know that I'm more aggressive with doing a biopsy, I'm more aggressive with treating the man. So it allows for us to do what we call personalized care for prostate cancer. It's not the same one fits all.
Yep.
So that's definitely a new innovation for prostate cancer.
Okay.
As it relates now to an enlarged prostate, which we call BPH, benign prostatic hyperplasia, we've had innovations over the years. You know, it's very common. 50% of men in their 50s will have an enlarged prostate, not due to cancer, and up to 70% in their 70s. And it's a bother to these men, because one of the symptoms that they'll have is just poor urinary stream. They go to the bathroom, it's a struggle to get the urine out, they have to be going very often, they can't urinate at all, and they may end up with a catheter. We call it stoppage of water in Jamaica. And so common it is that many men are on lifelong medication for these conditions. The problems with the medications are it may not be effective in every person, or if they do take it, there are side effects. And the big side effect men don't like to talk about is the erectile dysfunction, the sexual dysfunction, the lack of ejaculation. So traditionally, to treat this condition, we would do medication for lifelong, or if the medication doesn't work or there are complications, we take these patients to the operating room and we resect the prostate. But that itself comes with risks, and they have to be overnighting for at least a night or two in hospital. So where does innovation come into the clinical practice of medicine? We want to find something that is effective in treating this condition, that doesn't require long-term use of medication, that has low side effects, and that's now where the Resume water vapor therapy has come.
Resume water vapor therapy.
Yeah.
I was listening to you on our station a couple of weeks ago, and you were talking about men in reach my age. Is that what we're talking about? What's that on screen there?
That's right.
That's what we're
the Resume.
talking about. Yeah.
Correct.
So I was listening to you, and you were suggesting that men my age can get up plenty in the night and go and pee plenty. And
that's one of the symptoms.
That's one of the symptoms. I drink a lot, I think, well, you know me. And I mean, actually,
and that's a good thing, by the way.
It is a good thing.
To drink a lot of fluids, yes.
Yeah, I got up last night, it was about 11 o'clock, and went to the bathroom. Then I go to the fridge, and I went like that.
So you're provoking the whole thing.
Right.
Yeah.
So what's the issue there? Now, if I am getting up, I would think I get up probably about 3-4 times in the night.
So if it is driven by you drinking a lot at nights, then that may not be an issue. You can easily correct that by maybe drinking more during the daytime and restricting your nighttime drinking. But if someone really has a problem where regardless of whether they drink or not, they get up a lot at nights, it affects your sleep, it affects your productivity, and it's a nuisance. And if you're getting up, if you're going often during the daytime to urinate, can you imagine you're on set and you have to be running to the bathroom all the time? Those things affect your quality of life.
How you fix that?
Resume water vapor therapy is one option. It's a minimal invasive surgical therapy that is done in a doctor's office without the need for general anesthetic. So the advantage is that you don't have to be put to sleep. It doesn't have to be done in a major hospital. You're not overnighting, and it's effective. And what I do is I give a nerve block. So I block the nerves around the prostate, which is done, as I said, in a doctor's office. And then I insert an instrument in through the penis, through the urethra. And where the prostate is bulging in, if you look at the screen, you'll see a needle is injected into the prostate. But because it's been anesthetized before, the patient has no pain. The needle injects steam into the prostate. And think about it. If you put a tomato in boiling water, what happens? It just shrivels up. That steam kills the prostate cells in the vicinity. So where you would have the enlargement, that bulging, that is obstructing the flow, that is resulting in those symptoms, it's treated. And the patient will have to wear a urinary catheter to drain the urine for a couple of days, a week, maybe at most. And then over time, they'll find usually within a week or two, the tissue starts to be reabsorbed. They may see manifestations as early as 3 to 4 weeks, and they don't need to stay on medication long term.
I keep hearing over 40, over 40, over 40. Does that mean you cannot? Well, cannot, nothing is impossible, but you shouldn't get prostate cancer before that?
It can happen. I've treated men younger than 40 with prostate cancer in their late 30s. They did not fit the criteria for screening because they were less than 40, but they were compelled because of a strong family history, and I didn't turn them away. And it was significant prostate cancer that was diagnosed, and they were treated with surgery. So there are guidelines, but guidelines are not rigid. If patients say, listen, I have a strong family history, I want to know, and they're in their 30s, then we will do testing as well.
What's the prevalence in being successful in treating prostate cancer?
It's high if it's detected early. So it can be cured. We talk about cure rates in the excess of 95%, 5-year survival rates if persons are detected early. The challenge is if it is detected late, then there may be, You can't offer a cure, but you can at least control them.
Final question. You spoke about the blood test. Can I just go to any medical office and say, give me a blood test and check if I have cancer?
Absolutely. So you can go to your doctor's office and your doctor can request that blood test to be done.
And that doctor can, I don't have to come to somebody like you.
No, if you choose, I mean, there are persons like yourself who will see me as a urologist, and I'm happy to see you. But your family doctor, your trusted GP, or your health center clinic, they can request that blood test for you.
I was telling the story before we came on that I used to go see Dr. Morrison Blidgen every year to do the prostate cancer tests. I haven't gone for a few years. But there was this one year that I have never been so nervous in my life. I almost never came in because for some reason I just thought maybe I'm going to hear that I have cancer. I go in, she does the test, and she told me that I'm all right. And when she said it, I turned around and I just hold on to her and said, Doctor, I love you. She kind of looked at me like, huh? But I don't think I've ever been so happy in my life. Brilliant to see you.
Good to see you as well.
Yeah.
Thank you.
Screening recommendation?
40 every year. Get it done.
Is there anything that I could feel that could tell me that
Not
maybe?
at all, and that's the problem. You can be perfectly well, feel perfectly well, and you have prostate cancer. It's like walking over a cliff. When you start to have the symptoms, it usually means that it is too late. So do the test.
Good to see you. God bless you and your family.
Bless you.
Consultant urologist, Dr. Belinda Morrison Blidgen. 10 minutes to your health. We'll do it again next Thursday.